So thank you for the invitation. So this talk is a transition between what we've heard with regards to lysosomal storage disorders and genetics now into more allergic immunological problems. It seems to be a common theme, asthma, but there are forms of asthma that fall into rare disorders, and one of them is severe refractory asthma. These are my financial disclosures. So the objectives of this presentation is to understand the pathophysiology of refractory asthma and understanding the current and future treatment options for such disease. So what is severe refractory allergic asthma? It's a form of asthma where symptoms are persistent, so the patient continuously have asthma symptoms on a regular basis. There are frequent asthma attacks, and these frequent asthma attacks happen despite conventional treatment, and these patients also present with low lung function despite taking their regular asthma medications. So our thought process of asthma has changed nowadays a bit. In the old times, we used to think about a viral infection triggers a process where you now get allergic sensitization once exposed to allergens, and that results in an asthma phenotype. But the new concept is that the allergic sensitization comes first, followed by viral infections, which can then trigger asthma. So this has been a big shift in our thought paradigm. And the reason for that is rather than focusing on the viruses due to the airways, it's now focused to more what allergic sensitization can cause in the airways that would predispose to asthma. So let's look at it in a very superficial overview first. So on the left-hand side, you see the acute phase, and on the right-hand side, you see the late phase. I'm sorry, I don't have a pointer, so it's hard to point out to you, but what you can see on the left-hand side with the acute phase is that there's an allergen. It attaches to an allergic antibody called IgE. The IgE then triggers various immune cells, one of them being the mast cell, to cause release of inflammatory mediators, which results in muscle contraction, which will cause the wheezing and airway narrowing in patients with asthma, the production of mucus, which is one of the common symptoms, as well as the inflammation, which is the recruitment of white blood cells into the airways. Now you can also see the late phase. So this is the part that makes the asthma more a chronic disease. And the highlight here is the epithelial cell injury. That's different than what you see in the acute phase. So let's look at this in a little bit more deeper fashion. So I just talked to you about the epithelial damage. And on the left side of this slide, in the upper left corner, you see the allergens coming in. And the damage that's caused on the epithelial cells results in the release of some molecules. And these are important to know because they are focus of a lot of the current asthma research. These are chemicals like IL-25, IL-33, and something called TSLP. So these are some of the molecules that are released by tissue cells, not immune cells, but tissue cells, and they instruct our immune system cells to act in a way that will cause this allergic inflammation in the airways. And as you can see, the dendritic cell, the cell that's in purple towards the left with the little arms sticking out, is playing a very central role in directing the various cells of our immune system. Some of them are called T cells, some of them are called B cells, to produce mediators that will result in this further epithelial injury. So how does this epithelial injury look like? You can see here. Let me see if I can. So the epithelial layer here, and you can see damage. You can see here thickening of the So if you look on the so this is not going to work too. But the epithelium is damaged. You can see the little stars that show new blood vessel formation. You can also see collagen deposition shown by the arrow. So all of these added up together result in damage. Here on this slide, we're talking about epithelial remodeling. This is another name that's used after the damage happens. So the epithelium tries to regenerate itself, but that regeneration process then causes an issue, itself leading to more airway damage. On the upper part, you see control, and on the lower panel, you see an asthma patient, and you can appreciate the level of damage that happens in an asthmatic patient. So what do these mediators actually cause, these chemicals that are released by now the immune system cells after they're told by the epithelial cells of our airways to go do the damage that they're supposed to do? And on the right upper corner, you see a cell called a Th2 cell. This is a T cell that plays a predominant role in allergic inflammation. And the substances it makes, the major one being IL-13, results in significant mucus production in the airways. Another substance called IL-5, it attracts a cell called an eosinophil to the airway. The IL-13 molecule here will also cause smooth muscle cells to proliferate and to constrict actually. And chemicals like IL-4 and IL-13 will also lead to the production of generation of B cells that produce IgE. Now you'll see other cells down here, Th9, Th22, NKT cells, a new cell that's gained a lot of interest called the innate-like cell too. So there's many different cells within our immune system that play a role in this complex interaction in creating this inflammatory reaction. So this is a very simple view of how we think of allergy, autoimmunity. So allergy is a state where substances like that I've shown you, IL-4, IL-5, IL-9, IL-13, are overexpressed. So the balance is tipped in a direction where you get an allergic type inflammation in your airways. Whereas in autoimmune disorders, the one that's below that, the balance is tipped in a different direction. As you can see, the substances IL-4, 5, 9, and 13 are made less, but substances like interferon gamma and TNF-alpha and beta are made in more excess. And then this other cell comes into play. It's called the T regulatory cell, seen in part B. And this is a cell that plays an important role in creating a balance between these two. So what does these cells do? So we put that cell in the middle. What this cell does is it affects different components of the immune system. So going from the right in a clockwise fashion, it affects our dendritic cells. So these are cells that sort of trigger the initial phase of the immune reaction. These cells affect the tissue cells, such as the smooth muscle cells in our airways. They affect cells that cause immediate allergic reactions, such as the mast cells, the basophils, which release allergic mediators that cause acute symptoms of asthma. And they also affect the endothelial cells that line the blood vessels and have an impact in a beneficial way. So the most significant finding in patients when we treat them, and that gives us some evidence that these cells play an important role actually in patients, come from allergen immunotherapy. They're also called allergy shots. And it's a very ancient way of treating patients. It's been around for over 100 years now. And what we see is that when we do allergen immunotherapy to patients, there are certain cells that appear called T regulatory cells that has some special functions. So again, if we go from the top clockwise, these cells decrease allergen-specific IgE. They increase a substance called IL-10. So this is a very interesting finding that we see in patients with various allergies and asthma. After immunotherapy, the generation of these regulatory cells have an impact on disease progression. And as you go towards the right, you will see that IL-10 is also increased in monocytes. And if you go to the bottom of the slide, you see that the tissue numbers and the mediated release of the acute cells of the asthma, eosinophils and mast cells go down. But we also have a significant impact on the T cells, where these allergen-specific T cells and the various substances they make come down with the generation of these cells. So these findings in patients with allergen immunotherapy led to this current modern field looking into asking questions, well, what if we block these certain molecules specifically? How can we impact the asthma outcome. The first one that was available, which has been around for over 10 years now, is anti-IgE. It blocks IgE and it can cause various actions. It binds to the free IgE in the bloodstream. It decreases the expression of the high affinity IgE receptors on mast cells and dendritic cells, and it also decreases their mediator release, and it's shown to have a significant impact in reducing asthma exacerbations in patients. So this was one of the first biologicals that was available in a very, very targeted fashion, affecting disease outcome. But there's many others, so this is not the solution. And you can see that in the slide. Going from the left towards the right, as you can see, there's different chemical mediators that play a role in the asthma phenotype, and different pathways that are now being studied to be in a way that we can block them and ask the question whether the asthmatic inflammation improves. The two important ones that have gained a lot of interest and the trials have progressed significantly is IL-5, which is a eosinophilic cytokine, and that has shown significant progress in improving acute asthma attacks in patients receiving this medication. Another molecule that has gained a lot of interest and in works for the beneficial outcome in patients with asthma is IL-13. As opposed to IL-5, this blocking this pathway has shown significant impact in reducing the day-to-day asthma symptom scores of such patients. So in the last part of my talk, I'm going to take one of these molecules and give you an example on what's been done and what kind of outcomes have been obtained. This was a study that was published in the New England Journal of Medicine in 2011. These are looking at patients who have severe asthma, severe allergic asthma, and categorizing them into two different categories based on the expression of a serum biomarker called periostin. So taking patients with high periostin and low periostin and blocking IL-13 by a monoclonal antibody. On the right upper part of the slide, you see measurement of airway expiratory volume, and you can see in the bolded closed circles patients who received a medication that blocks IL-13, and in the bottom one is the placebo group, that you can see a significant improvement in airway FEV1, airway function in patients where IL-13 is blocked. But if you subdivide these patients into categories as high periostin and low periostin, which is looking at a biomarker, you can see that the high periostin group in B shows a better outcome than the patients who have low periostin. So studies like that has started to look, instruct us to look at several biomarkers to classify patients so we can do more targeted treatment. So I'm giving you an algorithm here. This is just a made-up algorithm. This is not a guideline, but you can potentially classify patients of having atopy, allergies, and no allergies. That's on the left side, and on the top you see high and low periostin. And based on these findings and published data, you can put patients into different categories and make a decision on what kind of targeted therapy would be of benefit to them. So for example, if you are an atopic person with a low periostin, perhaps targeting the IgE may be an option, whereas if you're a patient who has a high periostin level and is a very atopic patient, targeting IL-13 might be a better option. So we will see more and more of these algorithms and biomarkers as research in this field progresses. This is an interesting slide that's been published just recently, a couple months ago, by a group from Japan. And it classifies patients based on their blood neutrophil counts and eosinophil levels. It's very interesting. So they have cluster 1, 2, 3, and 4. The y-axis is the blood neutrophil count, and the x-axis is the blood eosinophil count. And what was very interesting is, depending on where you fall in these categories, your response to medications change, and your response to also becoming steroid resistant also changes. For example, patients who have high neutrophils in their blood and high eosinophil counts, which is cluster 4, seem to be a steroid resistant category, whereas patients who fall into cluster 2 and cluster 3, which are patients who have low blood neutrophil counts, but high blood eosinophil counts, seem to be more atopic and seem to respond to steroids in a better fashion. And finally, again, this is looking at the same patient population from the same publication. This here, looking at cluster 1, 2, 3, and 4, and looking at the serum periostin levels. So in the previous slide, I've only shown you neutrophil and eosinophil count, but when we look at the periostin, you will see in cluster 3, which was the more resistant group, a very, very distinct expression of high periostin in these patients compared to some of the others, which the expression level is very low. So I'd like to leave you with the message saying even some of the more common diseases that we see, such as asthma, have rare subcategories, and sometimes it's a very difficult task to manage them. But with more and more studies and research being done, our understanding of this disease category is improving. Thank you.